Okay, so if you are a 63-year-old male who
Yes,
has
doctor.
substernal chest pain, okay, so what is the
Oh,
mechanism of the
okay.
nitro?
Are you coming in tomorrow, Junior and Ma?
I'm sorry?
Reduce some anxiety.
Yeah, yeah. Feel it, yeah.
Mhm.
Yeah, so now what is the mechanism of nitroglycerin in decreasing the pain of angina?
So nitroglycerin
Yeah,
will decrease the preload.
excellent. Yeah, they love this question. So this decrease the
Mhm.
preload. So when when the heart doesn't have to work too much, so you don't have chest pain
Yeah,
because you
decreased
overwork.
oxygen
Yeah, exactly. Oxygen requirement. So that's
demand. Yeah.
yeah, yeah. So now if you are now this is a good case. So if you are a 60-year-old woman who came to the physician complaining of exertional dyspnea, okay, so I ordered labs. I found proteinuria and easy bruising. Okay, I examined you. I found uh, scattered by basilar crackles. I ordered echo. Echo shows small pericardial effusion with concentric thickening of the left ventricular wall. This is a typical presentation. So, what disease that can cause a proteinuria,
Okay.
pulmonary fibrosis, and pericardial thickening, concentric thickening? So, what medical condition that can cause that?
Pericardial thickening.
Yeah, concentric thickening of the ventricular wall.
Constrictive.
Constrictive.
Yeah, but constrictive pericarditis, this one only. So, which one disease that can cause constrictive pericarditis, pulmonary fibrosis, proteinuria, renal damage? So, which one that can cause that?
Amyloidosis.
Excellent. It is amyloidosis. It's caused by either rheumatoid arthritis, bronchiectasis can cause that, osteomyelitis, inflammatory bowel disease, Crohn disease, and malignancy, lymphoma, vasculitis. So basically, amyloidosis is the normal usual protein is alpha plated. I mean, it's a shape, it's alpha. When they become beta plated because of the inflammation, beta plated is difficult to be degraded by the enzymes. So this abnormal protein will go and accumulate on every possible tissue that you can imagine. So that's why they have asymptomatic proteinuria, nephrotic syndrome, and restrictive cardiomyopathy, hepatomegaly, peripheral neuropathy, autonomic neuropathy, macroglossia, bleeding diathesis, and they have waxy thickening and easy bruising of the skin. And how do you diagnose it?
The Congo red.
I
Oh, you can do the abdominal fat
excellent. Yeah,
pad.
I know you know that because you answered that before. Yeah, abdominal fat pad aspiration biopsy. You will find abnormal blood protein. Yeah. Okay, so if you have occasional chest discomfort with headache, okay, so what could be causing this condition? And you have an early diastolic murmur.
Early diastolic murmur.
Yeah,
Oh, okay. Occasional headache.
yeah. This is aortic regurg, right? The
Hmm.
pulmonary regurg and
Hmm.
aortic regurg causes early diastolic murmur, and they have bounding pulses. That's an important one. Okay. Okay. So if you are a 43-year-old woman who complain of fatigue, shortness of breath, I check your blood pressure is 98 over 55, pulse is 100, there's a JVD distension. So when I order chest X-ray, I found a bottle-like water bottle. So what is called? What is diagnosis?
Do you mind? Can you repeat the question again? I was a little bit distracted.
Okay, if I just tell you there's a water bottle sign on the chest X-ray, what does that tell you?
Hmm. Mm,
From just that.
I know. I know. I'm trying to remember which one again is water bottle. Water bottle will be. Don't say
Diabetic
it.
cardiomegaly.
It's a pericardial tamponade. When
Yeah.
yeah, when you
Hmm.
have pericardial effusion. Okay, and I can make it easier for you by giving you the Beck's triad, which is
Mm-hmm.
JVD distension and hypotension, tachycardia. Okay, that's it. Okay, so if you are an 82-year-old male who this is a good question and kind of tricky. So you have chronic back pain and your blood pressure is 160 over 80 while supine and 135 over 70 while standing. Why is this happening? What is the age-related changes can explain orthostatic hypotension in an 82-year-old?
Oh, so orthostatic is what is going on here.
Mhm.
Is it something to do with the valve?
So there is something is very interesting. It's called decreased baroreceptor
Or baroreceptor, yeah. Mm-hmm.
responsiveness. Okay, so that can happen. Okay, so if you made it through 80 and you survived, you didn't have an MI, you didn't have a osteoarthritis, colon cancer, you survived everything, then there is something waiting for you. Like there's the baroreceptor responsiveness will decrease, and yeah, it's time, man. Like that's it. So that's the thing. So now, if you are a 25-year-old woman with a blood pressure of 100 over 60, heart rate is 160. Okay, you always self-treated your like you self-treated by immersing your face in a cold water. Okay, so which one, like this cold immersion, how is that gonna help you? By what mechanism? Affecting what part of the heart when you have this? So this when you have this is a
So this
case,
you're talking
yeah,
about, okay, so
paroxysmal,
increased heart rate.
yeah, paroxysmal supraventricular tachycardia.
Mm-hmm.
So this PSVT. So how do we manage that, and what is the mechanism? So we manage it
Leave it.
by
Okay.
immersing she immerses her face in cold water. Okay, so by what mechanism that works?
So this is vagal maneuver, right?
Yeah, exactly.
And
Yeah,
it has something to do with the baroreceptors also.
yeah, it's with the AV node
Um,
conduction. Yeah, you're right.
yeah.
It's baroreceptors. Okay, slows the heart rate. Okay,
Mm-hmm.
and what medication is used for SVT?
Adenosine.
Yeah, adenosine.
If doesn't work, calcium channel blockers.
Yeah. Okay, so how about if I give you a case, patient present with SVT, you gave him adenosine, the patient died. What's causing that?
Hmm.
WPW.
Yeah, good job. Yeah.
Wolf Parkinson, yeah.
Yeah, this is well W. There was the question about it. It's a non-preventable adverse effect. Okay. So now the management of MI STEMI. Okay. So we give them oxygen if their arterial oxygen less than 90. We give them nitrate. But when we don't give, what is the quotient of nitrate? We are like in what condition we'll be careful with nitrate?
So nitrate, if they have a what do you call inferior MI and they have right ventricular infarction,
Excellent. Yeah. And
where they
hyper.
have a decreased preload.
Yeah, or when in case of hypotension too. That's also
Mhm.
okay. And then we give them antiplatelet aspirin plus P2Y2 receptor blocker. Okay, antiplatelet agent, and then we give them anticoagulation too. So we give them aspirin, clopidogrel, and unfractionated heparin, low molecular weight heparin, or bivalirudin. Okay, so this and then beta blocker. What are the contraindication for that?
So beta blocker will be if they have a bradycardia.
Yeah, or if
You
there
don't
is
do.
yeah, or if there is a high risk of cardiogenic shock, or
Mhm.
if there is a heart failure, we don't need that. Okay.
Okay.
And what's the ideal window for a PCI?
So PCI will be 90 minutes if they have a cath lab. So 120 minutes if they have to transport the patient to a facility to a facility with a cath lab. So 90, 120, and then something about the 12 hours from the onset of symptoms.
Yeah, yeah. And
So
you,
less than 90 minutes, less than 120, and then within 12 hours of symptoms onset.
yeah, yeah. So in a summary, you give them oxygen, nitrate, antiplatelet. You can give them dol, antiplatelet, anticoagulation, beta blocker,
You
PCI,
just
and
mentioned
statin.
all that, right?
Yeah, 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 yeah. So this is the summary, like this is summary. Okay, now this is a tricky case. Okay. So this they like to ask this one. Okay, it's like a renal artery stenosis, but in young. So this is how they describe it. In a 25-year-old woman presented with a blood pressure of 164 over 100. Okay, the plasma aldosterone over renin activity is 10. What is best next step?
Okay, we have to know the diagnosis first. Are you thinking fibromuscular dysplasia?
Yeah, excellent. Yeah, so you diagnose that by CT angiography of the abdomen.
Mm-hmm.
Okay. Yeah, so it's exactly like renal artery stenosis, but it gonna be in young people, mostly likely female. So the so which one that you screen for renal for fibromuscular dysplasia? What people you screen?
Which people do you screen?
Yeah,
I don't know. It's mostly seen in young women, right?
yeah. So if you have a woman less than 50 years old, plus
Mm-hmm.
any of the following, which is either severe or resistant hypertension,
Mm-hmm.
rise in creatinine by more than 1 milligram after AC inhibitor. That's you screen them for that. And
Okay.
then sudden increase in the blood pressure from baseline. That's also screen them for that. Onset of hypertension before age of 35, you screen them. Okay, when you have systolic diastolic bruit, that's a typical for it too. Okay, so the way it present with resistant hypertension, and that's a typical feature with it. It's very interesting. It can so this fibromuscular dysplasia can be anywhere, right? That's the thing would differ that make it different from renal artery stenosis. That's how they get you. So it can cause stroke, Horner syndrome, transient ischemic attack, and amaurosis fugax. Okay, that's a. What other symptoms can cause?
It can cause like a bruit, right? I remember the bruit, I think behind the ear or something like that. And also bruit in the renal, renal, renal artery bruit.
Hmm.
Something else, yeah. Yeah, all
Yeah,
those.
and this is the also they can trick you. They can bring they can add it can present with non-specific symptoms like headache, pulsatile tinnitus, dizziness from the
Mhm.
carotid and vertebral artery involvement. Okay, and it can involve anywhere. It can be in the iliac, subclavian, visceral artery, so it can cause mesenteric ischemia, it can cause intermittent claudication. So it can be anywhere. This fibromuscular dysplasia. So just watch out for that. Like they can trick you.
Mhm.
So just be careful for. Okay. So if the aldosterone over renin ratio, if it's more than 20, what is that?
If it's more than 20, you're talking about cones, hyperaldosteronism,
Yeah,
primary,
yeah, excellent. But if it's less than 20,
secondary.
then it could be either renal artery stenosis or
Radiatory
fibromuscular
stenosis,
dysplasia.
yeah. Hmm.
So the
CHF, all those ones.
yeah, so the first thing you do to diagnose them, you start non-invasive with a CT angiography. Okay, but what else? What after that? What do you do?
Um, Are you talking in terms of a management?
Yeah, if this you ordered CT and geography and that was negative, so what do you do after that?
Oh, okay. I don't know.
So do you order
Do
something?
you do, that's not, there is one that you do duplex ultrasound.
So you do it with catheter. You do catheter-based digital arteriography. That's how you diagnose it. If the CT angiograph was negative.
Catheter-based digital.
Arteriography.
Okay.
That's what they call it. Okay. That's the thing. And then you treat them medically, and you just follow up with creatinine every 3 to 4 months and ultrasound every how often?
I don't know. Is it 3 to 4 months?
So you
Every 3 to
yeah, creatinine every 3 to 4 months and ultrasound every 6 to 12 months.
6 to 12 months. Oh,
Yeah.
okay.
Yeah, Sahar, that will be helpful for you too, like because you know they can ask it in CK and step 3 too. That's a prognosis question.
Can you repeat that, please?
So fibromuscular dysplasia, you follow them up with renal ultrasound every year, and creatinine every 4 months. Okay.
And how's their prognosis? Is that good, bad?
It's different. It's totally different. Like from yeah, it's different. Depend on the stenosis, like the amount of obstruction
Okay.
and the dissemination. Like if it's only in the renal artery, then that's we can just do stenting and stuff. But if it's everywhere, like that's a worse prognosis. Okay, now this patient is an interesting case, and I think you guys will get it. So if you are a 60-year-old male who present with exertional dyspnea and fatigue over the last several weeks, now there's a very big clue. 2 months ago you had a heart attack, anterior wall heart attack. Now when I examine you, I found crackles, hollow systolic murmur. So I ordered echo. In echo, EKG, EKG, I found deep Q wave in lead 1, AVL, V2, V5, and 4 mm ST segment elevation and change from the discharge 2 months ago. So what's causing this issue?
Okay. Do you mind, can you just repeat it one more time?
Yeah, it's just a tough case. So this is so when
I'm trying to write something down, like some clues.
Yeah, so those are
60-year-old.
So those are one of the complications of MI. So if you had an MI 2 months ago and now presented with a hollow systolic murmur radiating to the axilla.
You say 6 months ago?
2 months ago.
2 months ago. Okay.
Okay. And now you presented with a hollow systolic murmur and EKG shows persistent ST elevation.
Persistent ST elevation. Okay. Are you talking about aneurysm?
Excellent. Yeah, that's what it is. That's an aneurysm. That's how you spot it. Let me. I'll write down some of the good questions that I think a little bit trickier. So when you have ST.
I have a question, Molly. Wouldn't it be chorda tendineae rupture?
What is it?
Would this be chorda tendineae rupture?
No, because this persistent ST elevation and deep Q wave 2 months afterward, that's an aneurysm.
The rupture will be like a, what do you call it, within less than 1 week, right?
So within 1 hours to 2 days, what is the most likely complication that can occur?
Arrhythmia.
Ventricular arrhythmia.
Arrhythmia, or can happen reinfarction too. How about ventricular septal rupture? When does that happen? What's the window for that?
Septal rupture, I think it depends on which book that you're reading, but basically it's going to be 3 to 5 days to less than 1 week.
Yeah, from hours, yeah, to week, 1 week. How about the free wall rupture?
Free war, I think up to 2 weeks.
Excellent, to 2 weeks. How about the post-infarction angina?
Post-infarction angina.
Yeah, that's a tough one. It's till 1 month can happen. From hours to 1 month. Okay. How about papillary muscle rupture?
Papillary muscle rupture, I think up to 1 week too.
Yeah, from 2 days to 1 week. Yeah, so if it's one rupture, it's gonna rupture in within 1 week, 2 weeks. It's not gonna rupture 2 months after. Like it's not gonna remember because it's a simple inflammation concept. The process of inflammation first comes the neutrophil, and then the fibroblast, and then by the fourth day, fifth day comes the macrophage. Okay, the macrophage starts eating everything, so that's the cause of rupture. So the most vulnerability of rupture within 7 days. That's what you gotta be. It's not gonna happen like 2 months after. How about pericarditis? What is the window for that?
Is it the acute one or the one? Okay, the pericarditis. If it's acute one, the 3 to 5 days. Then if you're talking about Dressler, I think about more than about 3 months.
Yeah, good job. Yeah, it's 1 day to 3 months. Yeah, and the left ventricular aneurysm. What is the window for that?
Yeah, just the one that you just presented.
Yeah,
Yeah.
it's 5 days to 3 months.
Mm-hmm.
So that's how. Yeah, it's a good important concept. This question. So let me just write that deep Q wave. 2 months after my. That's aneurysm. Okay. Do you guys see my screen?
Mm-hmm.
Okay.
Yeah.
Okay. This is gonna add some. Okay, let's go to the next one. Okay, so if you are a 68-year-old woman who comes to the emergency room due to a sudden onset of chest pain with vomiting, I check your blood pressure is 80/50, pulse is 60. Okay, when I examine you, I found diaphoresis, increased JVD, and positive Cosmal sign. When I do EKG, I found 2 mm ST elevation and 2-3 AVF, and ST depression and 1 AVL. What's causing your issue?
So likely she has MI.
Yeah, right ventricular
MI due to, you said right ventricular failure?
infarction. Yeah, right ventricular infarction, ST elevation in the right ventricle, because that's present with hypotension. That's the difference. Okay. So now, good question. So what are the causes of acquired long QT syndrome?
Oh, okay, let me see what I can remember. I remember the electrolytes, the hypomagnesemia, hypokalemia, hypocalcemia. Then you can have some medical conditions like hypothyroidism, things like that. You can have medications. Okay, bradycardia can also cause it, bradycardia hypothyroidism. Then all this ABCD, anti-arrhythmia, like sotalol, is it quinidine? Those ones. B will be, what is B again? ABC. Okay. C, antipsychotics medications. Also, TCAs can cause it. ABCD. D, anti-diarrhea, antiemetic, like ondansetron, can cause it. Yeah, bunch of things can cause.
Yeah.
Then okay, yeah. Tosad can cause it too, right? Tosad, the pointers. What else do I remember? I've said TCAs, right? SSRIs, psychotic medications. What other medications? Then the antibiotics too, the macrolides, right? The macrolides. Yeah. Okay,
Yeah.
I've tried.
Good job. Yeah, good try. So this is how I summarize them. I'd like to summarize them. When we have the medication causes, that's the most important one. I'll divide them into four groups. Number one is the one diuretic due to electrolyte imbalances and antiemetic and ondansetron. That's number one. The second then is the psychiatric. So number one, let's say gut stuff, abdomen. Second one, psychiatric, like antipsychotic, haloperidol, quetiapine, risperidone, TCA, SSRI, citalopram, for example. And then the third thing, heart stuff, chest, which is antiarrhythmic like amiodarone, sotalol, flecainide, and anti-anginal, for example, the ranolazine. And the fourth one is anti-infective drugs like macrolide, fluoroquinolone, antifungal, sorry. Okay?
Antifungal.
Yeah, anti-anginal is ranolazine. So then we have the metabolic disorders, like you said, hypokalemia, hypomagnesemia, hypocalcemia, starvation, hypothyroidism can cause that. And then obviously when you are bradyarrhythmic, for example, if you have sinus node dysfunction, AV block second or third degree, this can cause can cause the long QT. And then we have other causes, which is hypothermia, MI, intracardiac cranial disease can cause long QT syndrome, and HIV infection can cause long QT syndrome. It's interesting, the only infection that can cause long QT syndrome.
Which one? Oh, HIV, right?
Yeah.
Yeah.
It's
Starvation
interesting,
too.
yes. Yeah, like sometimes like this with medicine, you just have to know like there
How
is
do you remember all of them?
weird associations. Yeah, so luckily in the exam they're not gonna ask you to enumerate them. I'm taking you to a step further. Yeah. So you just gotta know them when you gotta recognize them when they are in a multiple choice question. So if they list couple of infections for you, okay, you gotta pick the HIV. That's how it is. So just know it so that you'll be able to pick it and the answer choices, yeah. For example, like if they put syphilis and HIV, syphilis can cause heart block, but HIV can cause long QT, so just be careful like this. Okay, so if you are a 67-year-old man who lost
67?
who lost consciousness while shoveling the snow. Okay.
Okay.
So what is your diagnosis? That's a pretty easy question.
Exertional syncope?
Yeah. And what do you
Aortic
find?
stenosis?
Yeah, they ask what do you find on auscultation. They wanted to make it a little bit harder. Systolic ejection murmur.
Right.
Obviously.
All those, what do you call it? Sometimes they'll ask you how do you say, L-tardus, parvus, whatever, delayed upstroke.
What is it? Yeah. Less parsas. Yeah, paras stardust. Yeah, stardust. Yeah. So, yeah, if you are a 55-year-old male who just feel breathless after running for a few for walking uphill, so this is scary, right? Like you feel breathless after walking. Come on. So I ordered EKG. I found ST depression in 2-3 AVF. What's the first line for your condition?
Okay, just breathless
Yeah.
after walking uphill.
Yeah. The bigger clue is the ST depression on EKG.
The 2-3, the inferior, or the depression. Okay. Depression, not elevation. Yeah, is it like a reciprocal something? I know all those weird reciprocals, but I don't remember which one is it.
No. This is a
It's not.
stable angina. Huh?
Angina.
Oh, stable and oh, depression. Okay.
Yeah. This is typical case of stable angina. They have chest pain, shortness of breath while walking.
Mm-hmm.
Okay, and then you find ST depression. So the first line for that, what is it?
Oh, stable angina, beta blocker treatment.
Yeah. Beta blocker is that improve exercise tolerance and relieve the angina by decreasing myocardial contractility. But if what if you have COPD? What what should I give you?
Oh, I think you can do those non selective beta blocker, right? Or
Yeah,
not?
no, yeah, you can do calcium channel blocker, can work too.
Mm-hmm.
Okay. And when do you give nitrate?
When do you give nitrate? When they have a chest pain?
Yeah, it's only in short acting in acute setting.
Mm-hmm.
Okay. And in long acting and added when there is a persistent angina.
Yeah,
Okay, you add that too.
yeah, chest pain, right? Yeah.
Yeah. So how to prevent angina, chronic angina?
Yeah, you give them all those, oh, how to prevent.
Yeah. You give them aspirin, statin, smoking cessation, regular exercise, weight loss,
Mm-hmm. Mm-hmm.
control blood pressure and diabetes. Okay.
Yeah.
Damn, I feel bad. Like I think after this step three, I should be a bodybuilder. Like I want to go to the gym every day. Like this is we don't want to get these things. It was like funny. Last time I was watching a video of Arnold. Okay, so Arnold, he's Australian immigrant. So he said one time he came from a poor family and everything. So he said one time I was looking to in a magazine and stuff. He said I always wanted to come to the U.S. This big buildings and big bridges and stuff like that. So he said I read I was in a magazine that your way to America, I have to go there. He said it was through a bodybuilding. Okay. So he started like there was a guy also. He was from Africa and he became a bodybuilder and then they call him
Mm-hmm.
Mr. Universe. I think that was before Arnold.
Mm-hmm.
And then he went there and this guy became very successful. So he said I wanted to follow the footstep of this guy. So he started doing the bodybuilding and then he came through the bodybuilding. So it was very interesting. Yeah. And then
Mm-hmm.
he was like an actor, like acted the
Mm-hmm.
movie of Terminator and stuff. And then he became the governor of California, which is
Mm-hmm.
a very interesting story. Yeah.
And then he's now back to square one, right?
Huh? What
Very
is it?
unpopular.
What is it? What is it?
I say now he's very unpopular, right?
Yeah. I think he gained some weight and stuff. Maybe.
Yeah, after he had a problem with his wife and sleeping with their maid.
Really? He had that? I didn't hear
Yeah,
about that.
he had
Really?
a son with their maid.
Really? Wow.
Yeah, and his son was growing up in his household.
Right, yeah.
Wow.
He impregnated the maid and the maid
Yeah.
had a son for him. The son looked exactly like him.
Wow.
I think he graduated college too now.
Right, yeah, he's out. His wife divorced him. Yeah,
Wow, I did not know that. Wow.
he's not popular anymore.
Recently, some guy punched him, and Arnold said he didn't even feel it, but somebody attacked him recently.
Oh, really? Wow.
I guess there's a downfall to everybody.
I know, yeah.
Wow, that's funny.
Most of the time, a woman will bring you down.
That's funny. Wow. Yeah. So now for a pulmonary hypertension, what are the signs for pulmonary hypertension? Back to the boring stuff.
Signs for pulmonary hypertension.
Yeah.
So, of course, they will have a dyspnea, right? Is that what you're asking? Okay, I'm talking about symptoms. You said signs.
Yeah, symptoms they have abdominal distension, syncope, exertional angina, dyspnea,
Mhm. Hmm.
fatigue. So what are the signs?
Um, so what I know is the one about the what do you call it, pulmonary artery, dilations, right ventricular um, pressure. They will have increased right ventricular pressure, right? They will have the pulmonary artery dilation and also pressure and things like that. I don't know what else.
Yeah, so you have left parasternal lift or prominent right ventricular heave. So this is in physical examination. When you put your hand on the chest of the patient on the left side, you feel heave like loop
Mm-hmm.
top, loop top, loop top, like this. Heave, or your finger will be lifted, and
Okay,
JVD,
they also, yeah, they have JVD too.
JVD,
Hmm.
load P2 and second heart sound and stuff.
So let me ask, they will have mostly things that has to do with like a right-sided heart failure, right?
Yeah,
Like having all the fluid backing up, like in the liver, having congestion of the liver, having hepatomegaly, right?
yeah, exactly.
Okay.
Yeah, they have all of these things, and they have this is very tricky one. They have loud P2 and second heart sound.
I hate heart
Yeah,
sounds.
yeah, loud P2 and second heart, and they have pan-systolic murmur of tricuspid regurg, and they
Mm,
have right-sided third heart sound S3, ascites and peripheral edema, hepatomegaly, called extremities.
mm,
So the one that you is a little bit harder to remember, the heave and the P2 of the second heart sound, and
mm-hmm.
they have the
Yeah.
third heart sound. Yeah, I remember there was like my professor. He was a cardiologist. He taught us these symptoms and stuff. But at the same
Mm-hmm.
time, he had the pack of cigarettes was showing from the back of his pocket. He had cigarettes all the time, and he was very obese.
Hmm.
Yeah, and he was a cardiologist. He was teaching us these things, and he was specialized in cardiopulmonary. But it was interesting. He was specialized in that, but he was smoking all the time. So it's very yeah,
Do what I say.
yeah.
Don't do what I do.
Yeah, exactly. Yeah, yeah,
Interesting. Yeah,
yeah,
doctors are the worst patients and the worst people that.
yeah. So there was a one time there was a student went and asked him like, so why do you smoke? Like you're telling us about COPD and stuff like. And then he started laughing. Oh, no, that's okay. No. He didn't answer. Yeah, it was funny. Yeah. So now, if you are a 64 white female, okay, who's taking digoxin, so what arrhythmia?
For white female.
Yeah. So what arrhythmia can happen due to digoxin?
Oh, that something atrial tachycardia, right?
Yeah, with AV block. So that's a
Mm-hmm.
very
Yeah.
interesting. Yeah, because it's an interesting mechanism. Increases contractility and increases vagal stimulation. So it can cause AV block and atrial tachycardia. So that's how it
Mm-hmm.
is. Okay, so if you are a 37 Cambodian woman who,
Cambodian.
yeah, who presented with the exertional dyspnea, nocturnal cough, and occasional hemoptysis for the past 6 months, okay, and you also describe episodes of palpitation and irregular heartbeat. So
Mm-hmm.
what's most likely diagnosis?
Mitral stenosis.
Yeah, mitral stenosis. So if you have a heart failure, cardiogenic shock, okay? So what's gonna happen to the cardiac index, systemic vascular resistance, and left ventricular and diastolic volume?
Okay, so cardiac index is gonna be low.
Yeah, good.
Okay, what else did you ask?
Left ventricular and diastolic volume.
Left ventricular and diastolic volume. Left ventricular and diastolic volume. So cardiogenic shock. It will be low, right?
No, because it's shock.
Oh, you
It's
have a
not
lot of
pumping.
the fluid that
Yeah,
is not pumping out. Yeah, it's high.
it's
Yeah,
high. Yeah, and the vascular resistance will be high too
high.
because
Yeah.
because the RAS. Okay. Okay, so if you are a 43-year-old woman with a lower extremity edema, okay, and you're taking antihypertensive, so what antihypertensive caused that?
Um, it will be like what do you call it? Amlodipine or things like calcium channel blocker.
Yeah,
Amlodipine.
yeah, good job, yeah, that's this thing. Okay, so if you are a 65-year-old Hispanic male who have chest pain, okay, and so I did an EKG, I found ST elevation in 2-3 AVF. Okay, your pulse is 60. Okay, S4 is here. Okay, so what's the goal to improve? Like, what should we do to improve your long-term prognosis right now? What's the best thing that can improve your long-term prognosis?
So pulse is 60.
Hmm? Yeah, that's it.
And so inferior MI, yeah, sometimes I get confused with that. I know you don't give them beta blocker. I don't know. This is not the time. This is the one you treat without doing PACE or
Yeah, so they're asking about the most specific thing that can really improve survival. Uh, it is that's the best treatment for that. Like you know you do all everything else, but the best one that improves survival, that it's a must, is the percutaneous transluminal coronary angioplasty within 90 minutes.
PCI.
Okay, or
The,
fib.
the way you ask these questions are a little.
Hmm?
Yeah, it's okay. Go ahead.
Yeah, that's how they asked it. So I'm asking you the same way. So and or fibrinolytics used from a door
Hmm.
to needle time of 30 minutes is the goal. So that's the most important factor in improving survival. Yeah. And actually, the way they wrote it and the answers, so they made it even harder. Like they tell you, decrease the blood coagulability, restore coronary blood flow, or prevent ischemia-induced arrhythmia. So the answer was restore coronary blood flow by the PCI. Okay, you gotta do it like immediately. That's the most important. So that's why if you're a cardiologist, you gotta buy a house next to the hospital, and you have to be there like anytime. Yeah. So if you are a 34-year-old male with a Wolff-Parkinson-White syndrome, EKG shows AFib of 160. So what should I do right now?
1 second. Go ahead. Let me answer my.
Sahar, you here?
Yeah. Give him,
Hmm?
oh, he has Wolf Parkinson, so we can't give him adenosine, right?
Yeah.
Hmm. I don't know. What's the other option?
Okay, sorry. What was the question again?
So Wolff-Parkinson-White syndrome with
Uh-huh. With
AFib of 160, okay? And he had
uh-huh.
3 episodes of SVT. What should you give him?
Mhm.
That's a very
Oh,
good
are you talking
question.
about giving them procainamide for treatment?
Excellent, yeah. If it's you give them. So it depends actually. If the patient is stable or unstable.
Oh, okay. So if the patient is stable, you do procainamide. If patient is unstable, you do synchronized cardioversion.
Yeah, electrical cardioversion. But if it's stable, you can give IV, butylite, or procainamide.
Mhm.
So what drugs that's a big no-no for Wolff Parkinson White syndrome?
The ABCD.
What?
So you don't give them, so you don't do ACE inhibitors, you don't do B for beta blocker, C calcium channel blocker, D digoxin, ABCD. Yeah. Yeah, so you don't do beta blocker, you don't do calcium channel blocker, you don't do ACE, and you don't do digoxin, ABCD.
Yeah. I just want you to change the A to adenosine, and everything else is
Oh,
right.
adenosine.
Okay. Yeah.
Adenosine, not ACE.
Yeah.
Okay.
Adenosine, beta blocker, calcium channel blocker, and digoxin. Yeah.
Okay. ABCD. I did not see. Okay.
Okay, so if you are a 21-year-old male present with a dizziness and palpitation that started abruptly an hour ago, I check your blood pressure, I found it 64 over 40. Pulse is 240. Okay? EKG is showing regular, narrow, complex tachycardia. So how can I treat you?
So this patient is unstable.
Yeah.
So for unstable patients, you have to go ahead and do synchronized cardioversion. What is the blood pressure again?
60 over 40.
Yeah, right?
So what if it's stable?
If it's stable, then you're dealing with like a SVT, right? So you start with vagal maneuver, adenosine, all that protocol.
Yeah, or you can give them amiodarone or procainamide too.
Oh, okay.
Okay, and then you also look at it if it's pulse, if there's a pulse, or if there's no
Oh,
pulse.
no pulse. Okay. So if there is a pulse,
What do you do?
then you do the synchronized. If there is no pulse, then you do the defibrillation.
Yeah, and you do first
They'll shock them.
CPR, IV access, and IV epinephrine too. Okay, and defib for sure, yeah. Okay, so if you are a 69-year-old male who had a cabbage, okay, just had a cabbage surgery, and now in the night you complained of weakness, chest tightness, and shortness of breath. Your blood pressure is 70 over 30, respiratory rate is 26, heart rate is 148. So what's the best next step in management?
The patient just had.
And
Repeat the first line again.
yeah, you just had a cabbage, like coronary artery bypass
Uh-huh.
surgery, and then you had hemodynamic instability plus atrial fibrillation on EKG. So what do you do?
You shock them. Oh, you do synchronized. I don't know why I say shock
So
them.
there's an EKG shows irregular RR interval, absent P wave, and narrow QRS complex. What do you do?
It's AFib, right? That you're talking about.
Yeah, but unstable.
Yeah. Synchronized cardioversion.
Yeah, yeah.
Isn't that what you do?
DC cardioversion. Yeah,
Yeah.
yeah,
Yeah, that's synchronized. Yeah.
yeah, yeah. Good job. Yeah. So that's the. Okay, so if you are a 62-year-old male who who had a history of bladder cancer and recurrent hematuria, okay, you came to the emergency room after passing out. Okay, you just went like you just went to the you woke up at night and you went to the restroom and you wanted to pee and you lost consciousness. So what's because you were peeing? So what's causing that?
Micturition, syncope.
Yeah, by what mechanism on the heart?
Oh, so micturition is a type of vasovagal, right? Or is it a type of orthostatic? I don't
Yeah, yeah,
remember.
it's
Yeah, it's a
vagal.
type of,
Yeah,
yeah.
vagal
Is it
and
like,
huh? Yeah, and can cause the heart, type 1 heart block.
yeah,
Yeah.
AV node?
So yeah, impaired AV node conduction. That's okay. It's very interesting. Like if you have this vagal, and they have so this Mobitz
I
type.
had somebody that died of that.
Really? Wow.
Yeah, yeah, yeah.
Wow, that's scary. How old was he? Like, oh shit.
He was 58. Yeah.
Wow, just lost consciousness like this?
Yeah, he went to the bathroom, to the restroom to use the restroom, and then, but I think maybe he also had a heart attack there. He just was peeing and passed out, and this next thing you know, he fell on the floor.
Wow, that's crazy.
Yeah,
Wow.
you know.
I feel bad for my dad right now. He had a heart attack and stuff, and
Oh, he did?
and he's like
When?
67 something. He had it like last year.
Mm.
Yeah,
My
Maybe.
dad too. He went through cabbage.
really.
He passed out outside the house, and
Oh,
4 arteries were blocked, and he had stenosis.
four vessels.
Yeah, yeah.
Oh wow.
Wow.
It's
Oh,
like
oh
a
my.
very complicated surgery he went through. It's like 8 hours of surgery, and he kept having ventricular arrhythmias. So last year, up until like January, February of this year, we were just dad was in rehab, cardiac rehab and everything. That's crazy stuff. Yeah.
Wow.
Mm.
Sorry to hear about that. Wow.
Wow. That's good. He's lucky.
I mean, he's alive. We're happy that he's alive and back home, but now he can't walk.
Really?
And
Why?
Oh.
Why?
they say it happens to some patients who go through such strenuous surgeries. It's like the conditioning is so terrible that he can't walk.
Oh
Wow.
wow.
Yeah, it's
What is
been,
it, the
Oh
prognosis?
my.
What they say? Like, is he gonna expect it to be better or something?
I don't know. It's hard to say at this point.
Hmm. Sorry to hear that.
Sorry to hear about that. Yeah.
And
No, it's tough.
yeah, with parents, you don't expect it, and it happens.
Yeah,
Yep.
that's tough. Yeah. Yeah. So if you are a 32-year-old male who have a 3-day history of fever and a murmur and needle track, okay, what do you expect? What's gonna happen to the murmur with inspiration?
Okay, so let's start from the beginning. So maybe this guy has endocarditis due to staph and affecting the tricuspid. So let's say tricuspid regurg, right? So tricuspid regurg, if it's gonna be when you decrease the preload, okay, the murmur is gonna be soft or lower with anything that decreases preload. Things like vaso Valsalva maneuver, also things like standing, using like a nitrate. So those are going to decrease preload and they cause the murmur to be soft. Then anything that will increase the, okay, things like, what do you call it? Um, leg raising, squatting, things that will increase the preload will make the murmur to be like higher, increasing intensity.
Wow, I'm very impressed. Good job. That's a wonderful job. Yeah, you worked so hard for this. Yeah. So it is the most common. That's a very good explanation. The most common that you gotta know that it's an infective endocarditis, and the most common Staph aureus and most common tricuspid. So tricuspid regurg. So the answer was like the systolic murmur increases with inspiration.
Okay.
Okay, so that's how it is. Like what you said, like because of the preload. So there are infective endocarditis in IV drug users. So HIV infection and increased infective endocarditis. That's one thing. Staph aureus is the most common, and right side of the heart more common than the aortic valve. Okay, and when you have a hollow systolic murmur that increases with inspiration, that indicate tricuspid involvement. Okay, this infective endocarditis can cause septic pulmonary emboli, so you can have PE.
Hmm.
Okay, and can cause to the fingers, cause splinter hemorrhage, Janeway lesion, and heart failure is more common in the aortic valve involvement, but rare with the tricuspid disease. So heart failure
Hmm.
can happen if the infective endocarditis in the aortic valve, but not with the tricuspid.
Hmm.
Okay, because it makes sense. Like if you're in the aortic, you tend to involve both sides of the heart, but if you're in tricuspid, you involve only the right side. So the
Okay.
left side will still be working. So that's the idea of this question. Okay, so now, so what is the mechanism of action of statin?
Or decrease the HMG, reductase enzyme, blocking that.
Yeah, inhibit intracellular HMG-CoA reductase inhibit and prevent conversion of HMG-CoA reductase to
Mm-hmm.
mevalonic acid
Mm-hmm.
and increases number of cell membrane of LDL receptors. That's why how it decreases the LDL.
Do you say increase or decrease the cell membrane LDL receptors?
Increases the receptors,
Increase the
so it will take
receptors.
more LDL, so the LDL in the blood will decrease.
Mm-hmm.
Okay, it's very, very interesting mechanism. Yeah,
Mm-hmm.
you can have it with a statin,
So
or
when
you
you
can.
increase the LDL receptors, the more the LDLs will bind to the receptors and be removed from the blood. Okay.
Yeah, exactly. Yeah,
Okay. Okay.
yeah.
I want it to make sense to me.
Yeah. You can have it with a statin, or you can have it with exercise. You choose. So that's one of the two things
Huh.
that, yeah, exercise can decrease
I need
LDL
to
too.
start exercising.
Yeah. Yeah. So if you are a 64-year-old male who have hypertension and you have a diet controlled diabetes and your blood pressure is 170 over 90, so what's the most appropriate next step in management? And your you have atrial fibrillation on EKG.
Okay. Are you talking about in terms of treating the like a chart score?
I'm sorry?
Okay. Okay. Say it again. How old?
Yeah, he's in his 60s and having hypertension with atrial
Uh-huh.
fibrillation.
Mm-hmm. Okay.
Okay,
I'm
so
calculating the chart score. So at least the chart score is greater than
he's,
2. So he's
yeah,
gonna be
uh-huh.
on anticoagulation.
Yeah, that's good. But what if I tell you the echo last year shows left atrial dilation and left ventricular hypertrophy? What do you give now?
Left atrial dilation and left ventricular hypertrophy. So chronic hypertension, you have to treat the hypertension. So, and he has a history of do you say he has a history of diabetes too?
Yeah.
So you have to treat the hypertension. So you give um so we are doing anticoagulation, and then I'm trying to see which anti-hypertensive medication to give. Yeah, ACE would be good, right? Any of those
Huh?
ones, I don't
So
know.
that's the trick for this question. So you just gotta be very careful for this. So if you have an atrial fibrillation, but the echo is fine, then you treat it with metoprolol. Okay? But and then with the chat fast for sure. But I'm
Mm-hmm.
just talking about the rate control. But if you have the echo shows left atrial dilation and left ventricular hypertrophy, so you have some heart failure features, so you give diltiazem. Okay? You,
Diethyism.
yeah.
Okay. Okay, you're talking about in terms of whether it's going to be beta blockers or whether it's going to be calcium channel blockers, right?
Yeah. And then you add the anticoagulation if the CHAD more than two.
Okay.
Okay? Okay. But what if the patient is unstable, the blood pressure is abnormal, like low? Then synchronize electrical cardioversion.
Sure.
Okay? Yeah. So let's do a really rapid review.
A really rapid review. What are we doing? What have we been doing?
Huh? It's more rapid, yes. It's like for whatever we did for today, and then we take 5 minutes of break, and then we come back, finish the rest of cardio. Hopefully, I'm hoping to finish all cardio by today.
Okay.
And then maybe I want to do also dermatology is tricky. Like there's a lot of tricky stuff in dermatology. Okay, yeah. Huh?
Dermatology is tricky.
Hmm?
Dermatology is very tricky.
Yeah, it is. It is very tricky. Yeah. So
Yeah.
let's do rapid review, like just a few concepts that I want to highlight here for this question. Okay, we said amyloidosis is multi-system. We discussed that amyloidosis we diagnose it by fat pad aspiration biopsy. If you have water bottle, that's a pericardial tamponade.
Mm-hmm.
If you are an 82-year-old with syncope, can happen due to decreased baroreceptor responsiveness. Okay. Vagal maneuver by immersing your face in the cold. That's an AV node conductivity affected. Okay. If you have hypertension and you are 25-year-old woman, most likely you have fibromuscular dysplasia. 2 months post MI, that's most likely an aneurysm. Okay, when you have 2-3 AVF, that's a right ventricular MI, especially if there's a hypotension. Causes of long QT could be macrolide, sotalol, ranolazine, ondansetron. Okay, the management of chronic angina by beta blocker, and you prevent it by statin aspirin. And pulmonary hypertension, you have loud P2 and second heart sound and S3, and you can have pansystolic murmur of tricuspid rigor. Digoxin causes the atrial tachycardia with AV block. Cambodian women who have hemoptysis, most likely mitral stenosis. Cardiogenic shock cause low cardiac index and high left ventricular end-diastolic volume. The antihypertensive cause edema, it's amlodipine. The most important factor that improves prognosis is the PCI in MI. Wolff, Parkinson, White syndrome, you want to avoid the ABCD, and if it's stable, you give them ibutylide or prekinamide. If unstable, critical cardioversion. Okay, if you are unstable with tachycardia, that's a cardioversion. Okay. If micturition syncope is due to impaired AV conduction. IV drug infective endocarditis causes systolic murmur that increases on inspiration, tricuspid rigor. Statin inhibit IgMGA corelatase. Diltiazem is the management of atrial fibrillation, especially if someone have heart failure. And rhythm control, if the rate control didn't work, then you add amiodarone. Okay, and if the CHAD more than 2, then you add anticoagulation. Okay, so now that's the summary of the third part of cardiology. So we'll take a 5-minute break and then we'll continue on the fourth part of cardiology, and I think it's the last one. Okay, so see you guys.